All right, well, thank you all. It's a pleasure to be here today, and I'm going to try to talk about two things today. One is about echocardiography, and then the other is about cardiac MRI. And to start off with, echocardiography has been around for quite some time. These are some pictures from the early to mid-1970s when echocardiography first came around with 2D echo. And since then, we've had significant advances in the modality, such that there's now contrast echo, there's transesophageal echo, we can also do stress echo, and then there's fancy Doppler-based techniques, color Doppler, spectral Doppler, and then things like strain imaging as well. But and then I think beyond echo, cardiac imaging I think is really rich in the sense that we've got also now nuclear cardiology, cardiac MRI, and cardiac CT. And so I'm going to touch on echo and CMR, and then I think our next speaker, Dr. Marian, will talk a little bit about nuclear cardiology and cardiac CTA. So what is the goal, or what's the use of echo? So the common uses of echocardiography, really first and foremost, I think, is assessment of LV function and LV size, all right? And that really is kind of the crux of what we do in cardiology to begin with. But then beyond that, it can also be useful in evaluating for the presence and severity of valve lesions, for pericardial effusions, pericardial constrictions. In patients who have atrial fibrillation, it can be useful to assess LV function, LA size, as well as for thrombus in the left atrium and specifically in the left atrial appendage. In patients that present with stroke, it can be useful to identify a potential etiology of stroke. It can be useful for identifying endocarditis and also for assessing aortic diseases. So let me pose a question to you in the audience here. So the question is, echo is such a good non-invasive imaging technique that every patient should have it. True or false? Okay, so this is a very astute audience here, and the answer is false. And the reason for that is we have to keep in mind that false positive results may lead to unnecessary and additional diagnostic testing, not only adding to cost, but also risk and discomfort to the patient. And therefore, it's very, very important that we do the right test for the right patient at the right time. I think that's the key message that I want people to go home with. And false negative delays may actually lead to, or false negative results may actually lead to a delay in making an accurate diagnosis as well as initiating therapy. So the concern with testing, if it's done inappropriately, is you may get false positive findings, but you may also get false negative findings. And we know that no test is perfect, and every test will suffer from some example cases of false positives as well as false negatives. And so the idea is really you want to utilize it in the appropriate patient population where you get the greatest diagnostic yield. All right, so now there's actually some data that Dr. Miguel Quinones put together from our echocardiography laboratory back last year, which was the number of stat echoes that were being done. So the combined data here is the total number of echoes that are being done in each month. The blue here is the number of stat echoes that are being done. And you can see there was actually kind of a rise, a creep forward in the number of stat echoes ordered to the point where almost 1 in 5 echoes that were ordered at Houston Methodist Hospital were ordered as a, quote, stat indication. And so one of the things that the laboratory did was simply by communicating this information back to the referring physician to say, hey, this is the number of echoes you ordered, of which this is the number of stat echoes that you ordered. By just communicating that information back to the referring, they noticed actually a decline in the percentage of stat indications. And the reality is, there's a small number of cases where it truly is stat. The echo needs to be done, but in the vast majority of the cases, it's not. And so we want to make sure that we don't overutilize testing. I think that's as important of a message as recognizing what the appropriate uses are. Now, what are the top 5 indications for stat echoes? Dyspnea, or shortness of breath, coronary artery disease, chest pain, pulmonary hypertension, and hypotension. And of 256 stats that were ordered in September, only 3% met appropriateness criteria. Because really the only appropriate what's considered to be appropriate indications for stat echo is if there's concern for aortic dissection, if there's hemodynamic collapse of the patient, so in other words, the patient has all of a sudden become unstable, or if the patient is in cardiac tamponade. And I think we can actually go to the document from the American College of Cardiology published in 2011 in JACC, which is the Journal of American College of Cardiology, which actually goes through and defines the appropriate criteria for echocardiography. And there's similar documents like this for cardiac MRI, for cardiac CT, as well as cardiac nuclear. And I think it's, these are long documents, but it's important to peruse through them, at least briefly, to get an idea. And one of the things that the documents highlights is that an appropriate study is one in which the expected incremental information combined with clinical judgment exceeds the expected negative consequences by a sufficiently wide margin for a specific indication so that the procedure is generally considered acceptable care and a reasonable approach for the indication. All right, so again, what these appropriateness criteria do is they actually go through and have a panel of physicians that they pull together, look at different clinical scenarios, and then actually try to score it. And then this is the composite score that's given. And then on a 1 to 9 point scale, a median score of between 7 and 9 is considered an appropriate test for a specific indication, meaning that most people feel it's appropriate or reasonable to do. A median score of between 4 to 6 is given an indication of a U, which means that it's uncertain whether this specific indication is appropriate or not. And then a median score between 1 to 3 is given a rating of an I, which means it's inappropriate for this particular indication. So obviously, things that are listed as A are things that we definitely want to do. Things that are listed as I, you definitely don't want to do. And the ones that are listed as a U are cases that are kind of borderline, basically. And so as I go through and show you these appropriateness criteria, I'm going to point to things that are appropriate as well as things that are considered I or inappropriate. So what are general rules when ordering a test? One is you need to know prior to ordering how will the test results influence your clinical decision, i.e. know the appropriateness criteria for a test. And I think this is very, very important because it's easy to kind of order test, but you need to think about, okay, so if I get this test, what am I going to do with the results of this test? Secondly is, I think we need to understand the Bayes theorem. How many of you know the Bayes theorem? Raise your hand. Okay, very few. Okay, nobody, or everybody's asleep. So I hope it's not that you're asleep. So, all right, so I'm going to touch on the Bayes theorem a little bit here. And the idea behind it is that no test is perfect. We know that. I mean, we are not living in a fairyland. We're living in the real world. The positive and negative predictive value of a test is dependent on its sensitivity and specificity, but is also dependent on the prevalence of the disease within the population to whom the test is applied. All right, and I'll touch on this a little bit more in a second here. So, for example, if I have a positive test result in a patient population that has 5% prevalence of disease, there's actually probably a good likelihood that this actually is a false positive test. And on the flip side, if you have a negative test result in a patient that has 95% likelihood of having disease, or a population that has 95% likelihood of having disease, it's very likely that you may actually be having a false negative. And so therefore, the best results are seen when you're dealing with kind of intermediate prevalence of disease. So prevalence of disease in the 30 to 70% range. And so I think the classic example of that is if somebody comes to you and gives you the classic presentation of angina, and they say, I'm having, this crushing substernal heaviness that I get when I walk, 2 blocks, and then it lasts for 5 or 10 minutes and then gets better when I stop. That's a classic presentation of angina, and the person says they've got diabetes, hypertension, is a cigarette smoker. Your pretest likelihood that this person is having coronary disease is very, very high. And so if I get a stress test on this person and the stress test comes back normal, there's probably a greater likelihood it's a false negative stress test than it is truly a truly negative stress test. The flip side, if somebody comes to you with very atypical chest pain, they say, oh yeah, I get this chest pain in my chest when I press on my chest, and it's there for the last 2 days. There again, it's a 20-year-old person who has no other risk factors for cardiovascular disease, the likelihood that that person, you do a stress test on that person and it comes back abnormal, there's a higher likelihood that that stress test is a false positive than it is a true positive result. So I think the idea is you need to know the milieu of the patient that you're testing, as well as what the diagnostic accuracy of the test results are. And so the idea is, in a low-risk individual, a positive test moves you now to an intermediate likelihood of having disease, not to saying the patient has disease. And in a high-risk individual, a negative test only moves you to an intermediate likelihood, not in ruling out the disease. And it's in the intermediate risk group of patients where a positive or negative test really takes you from intermediate to saying, yes, I think this person has disease, or no, I think this person does not have disease. And that's what this, I think, is trying to point out here, what I just touched on. So I'm going to skip past this slide here. So let's move on now to, so I think the basic point of that whole diatribe was really the idea that if you order the test in an appropriate patient population, that's when you're going to get the best incremental value from the test. Now, let's talk about evaluation of LV function, okay? So this is probably kind of the crux, the mainstay indication for which echocardiography is performed. Represents about 60 to 80% of clinical indications. And with echo, not only do you assess LV ejection fraction, but you can also assess LV size, so LV dimensions and volumes. And you can also assess for left ventricular hypertrophy via looking at wall thickness, as well as looking at left ventricular mass. Now, the methodology by which echo actually derives volumes and ejection fraction is by this method here, which is called the modified Simpson's rule of disc. So you actually trace on a 4-chamber view and a 2-chamber view of the heart the area as well as the length, and then it assumes that there's a circular disc between these two geometries, so there is some geometric assumptions that are being made, and it summates this, and it derives for you a volume in end diastole. You do the same thing in systole, and it gives you a volume in systole, and from that you can derive ejection fraction. Now, we've got newer echo techniques where we use 3-dimensional echo, so now you're not making geometric assumptions, but you actually can image the entire left ventricle and generate a shell of the left ventricle, and there's some automatic border detection techniques which can aid in this. But again, you can see the image quality generally with 3D echo is not as good as the image quality with 2D echo. So, you know, when it comes to LV function assessment, although 2D echo is the mainstay, oftentimes we will utilize 3D echo as well. And what are common scenarios in which you want to assess LV function? One is if a patient's had a recent or an old MI, knowing what their LV function is very, very important. It's a powerful predictor of prognosis. If you have a patient who's coming in with chest pain, a resting echo may in fact be of minimal value, unless the patient's actively having chest pain at the time that you're doing the imaging. If you have a patient who comes in with dyspnea or with heart failure, in that case, assessment of LV function with echo can be very, very useful. And then if you have somebody who has an abnormal EKG, such as left bundle, LVH, SDT changes, or Q waves, then an echo for assessment of LV function can be very useful in this setting. And then also, if you have cardiomegaly on a chest x-ray, that can be a useful indication for echo. And then systemic hypertension, where we're looking for LVH when the EKG findings are equivocal. And then obviously in patients that are getting cardiotoxic drugs, you know, that's one indication where serial echo monitoring can be very useful clinically. And then for patients that are going for major cardiac surgery who have suspected heart disease, getting an echo prior to that can be useful. Now, if you go to that appropriate use criteria document that I talked about, they have lots of tables like this. And again, remember as I mentioned, an A is considered appropriate, I is considered inappropriate, and then a U is kind of a border zone, it's uncertain. So what you want to say is the ones that are A are the ones which are clearly indicated indications for an echo. So if you have somebody who has suspected cardiac etiology, symptoms or conditions that are related to suspected cardiac etiology, but not limited to chest pain, shortness of breath, palpitations, TIA, stroke, or peripheral embolic events. That's an appropriate indication for an echo. When you have prior tests that's concerning for heart disease or structural abnormality, including but not limited to chest x-rays, baseline scout images for stress echo, EKGs, or cardiac biomarkers. That's also considered an appropriate indication for echo. But some inappropriate indications for echo would be somebody who has infrequent PACs or PVCs without any other evidence of heart disease. So just simply seeing some PVCs on a monitor is probably not an appropriate indication to get an echo. Somebody who has asymptomatic sinus bradycardia in isolation, that probably also is not an appropriate indication for getting an echo. So again, you can pull these documents up and look at all of these things, but this gives you kind of an idea of the flavor of what are considered appropriate things and what are considered inappropriate things. Now, a common indication that we use for getting an echo is hypertension. So in fact, it is appropriate for the initial evaluation of a patient with suspected hypertensive heart disease, but it's really not indicated for routine evaluation of known hypertensive heart disease without any change in clinical status, or patients who have hypertension but who don't have any signs or symptoms of hypertensive heart disease. Now, what about pre-op evaluation? So you'll notice there is no A's here. It's all inappropriate or uncertain. So kind of routine assessment with echo for prior to any surgery is not really indicated. What about, now I'll talk about some areas where it could be later, but what about pulmonary hypertension? So obviously, if you have a patient with suspected pulmonary hypertension, including evaluation of right ventricular function and estimation of pulmonary artery pressures, that's a very appropriate indication, as is routine surveillance beyond 1 year of patients with known pulmonary hypertension without a change in clinical status. But within a year, in a pulmonary hypertension patient, unless there's a change in clinical status, it's not really appropriate to keep repeating echoes. And then obviously, if there's a change in clinical status, or if you're using it to guide pharmacologic therapy, then reevaluation is useful in the pulmonary hypertension patient. So I think the theme that you'll notice here is what it's saying is that, beyond the initial assessment, kind of repeat serial testing with echo is really going to be primarily only indicated if there's somehow a change in symptoms or a change in clinical status. So change in physical exam findings or change in symptomatology. This is now what the guidelines talk about when it comes to preoperative use of echo. And so in the, what I showed you before was appropriate use criteria. Now this actually is actual guidelines. And in the guidelines, they basically classify as class 1, class 2, and class 3. Class 1 is definitely indicated. Class 3 is do not do. And then class 2 is kind of in between. So it's definitely indicated if you have patients with current or poorly controlled heart failure without a recent EF measurement. But it's not indicated, it's actually maybe harmful to do routine preoperative checks of LV function with echocardiography. And then again, it's kind of in the intermediate for patients with a prior history of CHF if they're having some dyspnea that's of questionable etiology. Okay. So let's go back to the appropriateness criteria. And again, when it's considered appropriate, so what we said is that it's not appropriate for every single surgery to get a echo done beforehand. So which cases is it appropriate? So it's considered to be appropriate in patients who are going for vascular surgery, where you want to do a stress echo, especially if they have greater than 1 clinical risk factor, or they have poor or unknown functional capacity, meaning less than 4 METs of exercise tolerance. And really, everything else, all the other indications, are considered inappropriate or uncertain. So for patients with low-risk surgery, even for intermediate-risk surgery, there's not a clear-cut indication to get any kind of echo assessment on these patients beforehand. Again, unless they have either clinical symptoms of heart failure, or they're undergoing vascular surgery and they have some clinical risk factors for heart disease. Now, what about in the assessment of chest pain? So as I talked about already, in the assessment of chest pain, resting echo is often of very limited value, with the exception of if a person is having active ongoing chest pain at the time that you're doing the echo. If you're concerned about an acute MI or unstable angina, it could also be helpful if you're trying to look for pericarditis, because you may see a pericardial effusion that's associated with pericarditis. If your concern is for aortic dissection, for hypertrophic cardiomyopathy, or if you have EKG abnormalities at baseline, such as left bundle branch block, LVH, or significant STT abnormalities. Those are indications where it may be appropriate. But for the vast majority of patients coming in for evaluation of chest pain, a routine echo assessment is probably not needed in those patients. Now, stress echo could be appropriate, all right, and that's different because a resting echo is different than a stress echo. In a stress echo, we're actually imaging it, doing baseline images at rest, but then stressing the heart and seeing what happens to wall motion with exercise or with pharmacologic testing. Now, let's talk a little bit about echo-based stress testing modalities, okay? So stress echo. And really, you can break it down into two groups of categories. There's exercise-based echo techniques, and then there's pharmacologic-based echo techniques. So exercise-based echo techniques would be either with a treadmill, where you exercise a patient on a treadmill, you rapidly get the patient off of the treadmill and quickly do imaging to see if there's any evidence of wall motion abnormalities. Or we can do a bicycle exercise where you're imaging as the patient is doing bicycle exercise. And then, in addition to exercise-based techniques, you can do pharmacologic-based techniques with dobutamine echo or dipridamole or adenosine with echo. Now, nowadays, we don't do dipridamole or adenosine echo very often. So if we're going to do pharmacologic stress with echo, it's going to be primarily done with dobutamine. Let me show you an example of what a stress echo looks like. Now, you'll notice in this case, there's contrast that's been given. And again, the reason for giving contrast is that it improves your visualization of the wall. Now, this is what's called a bicycle echo. So you have basically rest images that are obtained, and then you're obtaining another set of images at 25 watts of exercise, at 50 watts of exercise, and then at peak exercise. And you'll notice on this 4-chamber view, at rest, everything seems to contract normally. So if you look at the size of the cavity between diastole and systole, it gets smaller, right? And you can look at the septum here, the apex, and the lateral wall, and all the walls seem to contract. At 25 mics or 25 watts, you can see kind of a further augmentation in contractility such that the cavity size at the smallest cavity size in systole here compared to here, it's smaller actually at this stage, and it gets even smaller, so you're getting further augmentation in contractility. And notice what happens at this stage here, peak exercise. Look at that lateral wall, right? You can see it's not contracting like it was before. So you actually had a lateral wall that improved initially, and then it got worse. That's the classic finding that we see indicative of ischemia. And lateral wall here would correspond to circumflex territory. So this is an abnormal bicycle echo suggestive of a disease in the left circumflex coronary artery territory. Everybody see that? Okay, it's not always that clear cut, but that's a nice example case. Now, this gets back to why the importance of the Bayes theorem, which is if you look at the literature, what is the diagnostic accuracy? So for an exercise echo, the sensitivity is 85% and the specificity is 77%. Okay? Now that's better than an exercise EKG, just a plain old treadmill, where the sensitivity is 52% and the specificity is 71%. So it's better, but it's not 100%, right? And even if you look at exercise SPECT, has a sensitivity of 87%, but a specificity of 64%. So the difference really between an exercise echo and an exercise SPECT is that the exercise echo tends to have a little bit of a higher specificity, whereas exercise SPECT or nuclear has a little bit higher of a sensitivity, okay? But notice, none of these are 100%. And as I'll show you, even with cardiac MRI, you don't achieve 100% diagnostic accuracy. And so as a result, there's always the concern of false negative test results as well as false positive test results. Now here's a pharmacologic stress test. So this is done with dobutamine. And with dobutamine, what we typically do is we start out at baseline. This is at rest. And then you give 5 mics of dobutamine and image, give 10 mics of dobutamine image, and then you go all the way up to peak, 85% of maximum predicted heart rate for the patient, and then re-image again. This was at 40 mics plus atropine administration. And if you look here, what do you guys think? If you compare it, look at the walls and look at the size of the cavity at baseline at this stage here, it looks like the cavity size gets smaller. All the walls seem to improve. Even at this stage, it looks like the septum and the lateral wall improve. But if you look at this stage, what do you notice? This area in the apex here doesn't seem to really improve. And the inferior wall here, or the septal wall here, doesn't seem to augment, right? And you'll notice, look at the size of the cavity in systole here compared to the size of the cavity in systole here. You notice it's actually a bigger cavity. So this is an abnormal test, right? And you can see that both on the 4-chamber view, which is showing us the septum and the lateral wall, or if we look at the 2-chamber view here and focus in on the apex again, this is showing you the inferior wall and the anterior wall. And again, you can see this abnormality here where the apex looks like it's ballooned. It's gotten bigger actually during systole than it was before. So this is an abnormal finding, indicative again of inducible wall motion abnormality suggesting coronary artery disease in this patient. Now, what are considered appropriate indications for stress echo? And so really, these are a list of appropriate indications shown here. Now, what's considered inappropriate is if you have a patient who has a low pretest probability of CAD and who has an EKG that's interpretable and is able to exercise, right? Because if the EKG is normal, patient's able to exercise, and they have a low likelihood of CAD, there's probably not a role for doing any kind of stress echo testing. You may just need to do a plain old treadmill, or you may not even need to do anything for this patient. On the flip side, if you have a person who has a high likelihood of CAD, that's a person who would benefit from stress echo, or people with intermediate pretest likelihood of CAD who either are not able to exercise or who have EKG that's not interpretable. So baseline EKG that's abnormal. Those are all cases where you'd want to do a stress echo, not just a plain old treadmill, not just a plain old exercise stress test. And then, whenever possible, if the patient's able to exercise, it's always better to do exercise than pharmacologic testing. Okay, that's a very, very important principle, I think, to go away with. And the reason is because exercise is much more physiologic. And exercise gives us a lot of prognostic information over and above what we see as far as wall motion abnormalities on the echo. So simply, if a patient's able to exercise for 10 or 12 minutes, that in of itself tells you there's a very good prognosis for this person versus a patient who's only able to exercise for 3 minutes. So I think we need to put the imaging findings, the echo findings, in context with the exercise duration and the exercise capacity of the patient. So let me show you some example cases. So here's a patient on the left here. You can see, if I look at the resting echo on this patient, and that we're talking about now is heart failure. This person has depressed EF, right? You can see the cavity size doesn't really change that much between diastole and systole. This EF here is probably on the order of about 20% or so. So significantly impaired LV function. On the flip side, this person here, who also has heart failure, but who has actually thick walls and has normal LV function. Now remember, heart failure doesn't mean LV dysfunction. In fact, half of all cases of heart failure almost in the United States are what we call diastolic, or heart failure with preserved ejection fraction. So you can have normal EF and still have heart failure, but it's important to stratify a patient who has heart failure into those with depressed EF, what we call heart failure with reduced ejection fraction, or HFrEF, versus people with preserved ejection fraction, or HFpEF, heart failure with preserved ejection fraction. And then beyond assessing LV function, echo can also help you with hemodynamics, determining the etiology of heart failure, such as valvular, ischemic, restrictive. Can also help you with pulmonary hypertension, and then with assessment of prognosis. So these are all the different pieces of data that you actually can get from an echo in a patient that's presenting with heart failure, which is size, ejection fraction, RV function, stroke volume, cardiac output, pulmonary artery pressures, estimates of filling pressure, and then assess severity of valvular regurgitation. So in the interest of time, let me skip past a couple of these slides here. An important kind of simple, I like to think of this as kind of a poor man's algorithm of where, if you have a patient presenting with new onset dyspnea, where biomarkers in an echo could have a role, all right? And so we're all familiar with BNP, which is a biomarker of atrial stretch and volume overload. If you have a patient with normal BNP, it's very unlikely that this person's dyspnea is due to heart failure, and you really should look for non-cardiac causes. On the flip side, if you have a patient with a very high BNP, that's a scenario where there's certainly a higher likelihood that this could actually be heart failure. And this is a case where echo could be useful not only to assess ejection fraction, because remember I said you can have heart failure and have a normal ejection fraction. So having an abnormal ejection fraction is not required to have heart failure. But where echo can come in beyond assessing LV function is morphology. So looking for LV hypertrophy, looking for estimates of filling pressure, what's the left ventricular filling pressure as well as pulmonary artery pressures to help you in determining the diagnosis of somebody's heart failure, or at least potential etiology of somebody's heart failure. And then obviously if you have somebody who's got an intermediate BNP between the 100 and 300 range, that's an area where an echo can be helpful to try to help identify if this person's dyspnea symptoms are in fact heart failure related or not heart failure related. Okay, so let's get past here. And this actually goes through and talks about the appropriate indications for an echo in the patient with heart failure. And you can see there's a fair number of A's here, appropriate indications. And really, initial evaluation of a patient with known or suspected heart failure, whether it's systolic or diastolic heart failure, an echo can be very, very appropriate. And then also for reevaluation of a patient with known heart failure, if there's a change in clinical status or change in cardiac exam without a clear precipitating change in medication or diet, okay? But it's not appropriate for every person that comes in with recurrent heart failure. So it's really if there's a reason to suspect a change in their clinical status, that's when it's considered appropriate. Now, obviously, if you have patients with ventricular assist devices or cardiac transplantation, those are patients that have very appropriate indications for undergoing echo, as are patients who have known cardiomyopathies. So I'm not going to belabor that point too much. Echo is also going to be very important for assessment of valvular heart disease, whether it's aortic stenosis, aortic regurgitation, mitral regurgitation, mitral stenosis, or tricuspid regurgitation as well. And let me talk about some common clinical scenarios where you would use an echo in valvular heart disease. So if you have a heart murmur that you don't know what the etiology of it is, that's where you'd want to get an echo. If you want to assess the severity and or cardiac function in a patient who has known valvular disease, to help you in determining what's the optimal time to operate on somebody with known valve disease. So if somebody has mitral regurg, when do you decide to operate on this patient? If you're trying to decide suitability of a valve repair or a transcatheter procedure, those are all indications. And then obviously if you have a prosthetic valve that you're suspecting is dysfunctional, that could be an indication as well. And then serial evaluation after valve repair or replacement. Notice annual assessment in the absence of any new symptoms is not an indication. So again, I think the flavor here is you're really looking for new symptoms, a change in symptoms, or a change in the patient's clinical status. That's when you want to proceed on with getting testing. So let me skip past prosthetic valves here. And then just a couple of slides to highlight cases where it's not appropriate or cost effective to get an echo. So routine checkup in asymptomatic patients with no signs or symptoms of heart disease. In an ambulatory patient with recurrent chest pain and no specific abnormalities on physical exam, chest x-ray, or EKG, that's a case where just a resting echo is not appropriate. Now, a stress echo to look for inducible abnormalities could be appropriate. Patients who have palpitations without any identifiable arrhythmias or specific abnormalities on EKG or physical exam, that's probably where an echo is not appropriate. In elderly patients with strokes in whom anticoagulation is indicated anyway, or who have a well-established risk factor for stroke, those are cases where the echo may not change your clinical management. And then if you have very young patients with an innocent murmur that sounds benign, without any abnormalities on physical exam or EKG, those are also scenarios where an echo would not be appropriate. So let me pause here. I'm going to switch over to the next slide and just briefly talk about MRI. I wanted to focus this talk on echo because, again, echo is really going to be your first line modality, and MRI really is much more of a second line modality when it comes to assessment of cardiac patients. So let me pull up the MRI slides here. And what I want to do here is not delve too much into the details of how cardiac MRI is done, but rather talk a little bit about what it is and what we use it for. So obviously, this is a picture of a scanner. So you can see it's like this donut-like machine. Patients lay on this table. This table then goes inside the scanner, and we image the patient. Now you'll notice down here at the bed of the table, or at the foot of the bed here, there's actually headphones that we put on the patient's ears, because you know the MRI makes a loud banging noise, and we don't want to destroy the patient's ears. So it's important to have headphones on them to protect their ears. Also, for us to be able to communicate with them, because you can't really talk to a patient when there's a loud banging noise going on unless there's headphones. So MRI actually can do a wide variety of different things, from valve assessment, cardiac masses, perfusion imaging to look for stress, to do stress testing, RV dysplasia, viability, constriction, aortic diseases, and anomalous coronaries. But for the purpose of this talk, what I want to talk a little bit about is, what patients can get an MRI, and importantly, what patients cannot get an MRI. And so the first thing we need to understand is the terminology with regard to MRI safety. All right? So any device now has to have FDA labeling, whether it's MRI safe, MRI conditional, or MRI unsafe. Now, MRI unsafe obviously is something that would pose a hazard to going into the MRI environment. And so if a patient has an MRI unsafe device, they should not get an MRI. That's the end of it. Now, an MRI safe device, you'll notice very few devices will actually be labeled as MRI safe. And the reason for that is this is one in which the item poses no known hazards in an MRI environment. And using this terminology really only applies to something that's non-metallic. So there cannot be any metallic component. And so the vast majority of things are going to be given the labeling of MRI conditional. And what that means is that there's been safety demonstrated in specific imaging environments with specific sets of conditions. And I think this is very, very important to keep in mind. And I'll give you an example of why this is important. So how many of you have been to Vegas? About a third. So you guys, some of you have missed out. All right, so there's a new complex that came out in Vegas, latter part of last decade, the City Center complex, and one of the hotels there was the Vdara Hotel. Has anybody stayed at the Vdara Hotel? So we got a few people that have. Okay, did you go down to the swimming pool there at the Vdara? So you know that the Vdara actually got some bad press a few years after it was built with this concern of death rays in the pool.
Thinking of taking a road trip to Vegas, be warned. The new MGM hotel there called the Vdara has been found to contain an extra you definitely don't want. It turns out when the sun's rays hit that curved building, it creates a 15-foot wide hotspot on the ground that is so brutal it can burn hair and skin and even melt plastic. Some unlucky hotel guests have been sent running from the pool area after being caught in what hotel employees are calling the death ray, a burning sensation from above. The hotel is rushing to fix the problem.
So what happened? So here's what happened, which is, obviously this is a beautiful building with lots of glass, right? And the glass reflects sunlight. And what happened is that a few days in the year, the sunlight is just right, and it reflects in such a way that this curved building causes the rays to be concentrated in this one kind of 10-foot area of the pool, in the middle of the pool. Now, it doesn't happen every day of the year, doesn't happen every time of the year. It's only for a few hours, a certain time of the year, that this can happen. So the point of this is that when you talk about safety, the only way you can talk about safety is if you examine every possible permutation of combinations. And you can't possibly do that. And that's why the FDA, when they talk about MRI devices, has moved away from saying it's MRI safe and rather saying it's MRI conditional, which means that when they try to test in a variety of clinical scenarios, it doesn't demonstrate safety risk. But that doesn't mean that it's safe in every single possible scenario, because again, if you're in this pool for those 2 days of the year, for those 2 hours of that day, clearly it's not going to be a pleasant experience. So I think that's what this brings out. And so even devices that are considered MRI conditional, we need to still carefully watch those patients and monitor those patients. And you should only do those patients if they absolutely have a good indication to get imaging done. Now, I don't expect anybody to memorize all devices and whether they're MRI safe or not. And this unfortunately doesn't project that well, but if you go to this website right here called MRIsafety.com, so if you're taking care of a patient and they're needing an MRI scan and they have a device, whether it's a pacemaker or some kind of a clip or whatever, you can actually go to this website, and on the left-hand side there's a thing called the list. You click on that, and it actually brings up this interface right here, where you actually just enter in the name of the device. So you say Boston Scientific Stent, and it will actually give you the list of all those devices, and it will tell you whether it's labeled as MRI safe, MRI conditional, or MRI unsafe, and it'll also tell you what field strengths it's been tested with, whether it's 1.5 Tesla scanner, or 3 Tesla scanner, or both, or neither. So it's always important, if you have a patient with a device, get the card of what kind of device they have, and look it up on this website. And that's probably, from the MRI standpoint, that's probably the most important thing if I can convey to you. And the one thing you don't ever want to do is have a patient get an MRI scan not knowing that they actually have a device in place. That's when you can have a problem. All right, so it's always important to screen these patients carefully. If they have a device, we want to know exactly what kind they have. And if they have a device, we look it up and find out if this device, this particular device is safe for the scanning conditions that we're going to look at. And so oftentimes we'll have patients that are scheduled to be done on the 3T scanner, but the device they have is considered MRI conditional, but MRI conditional at 1.5T, so then they need to be moved over to a different scanner. So that's where you guys can help us. If we know this information beforehand, it can help us in appropriately positioning the patient to the right scanner facility. And I think this applies for both cardiac MRI as well as non-cardiac MRI as well. Another important thing I want to make sure everybody leaves home with is the idea the magnet is always on. Okay, so if you happen to be down there at nighttime and the lights are out and nobody's there, the magnet's not turned off. Okay, the magnetic field is always on, and remember, this magnetic field becomes a projectile. An object, a metallic object that enters the room becomes a projectile and accelerates as it gets closer to the magnet, and therefore there's cases of death that have occurred when somebody goes into the room without realizing they're having a metallic device. So, you know, if a code is called in the MRI suite, the first thing we do is shut the door, get the patient out, and shut the door. So, you know, if you ever get called to a code in the MRI, don't go running into the MRI room itself to try to save the patient, because you probably will just kill the patient. Instead, wait outside, take off all your metallic stuff, and then get somebody to get the patient out of the room, and then you begin doing CPR outside of the MRI room. So I've got about 2 minutes, 2-3 minutes left. So I'm going to kind of quickly highlight a few indications where MRI is useful. So obviously for valvular function, or for ventricular function, when an echo is suboptimal, echo is equivocal, those are indications we move on to MRI, because MRI can give you much more precise and detailed information about ventricular function. In the setting of valvular heart disease, again, when an echo is suboptimal or equivocal, that's where you'd move on to get an MRI performed, whether it's for aortic valve disease, whether it's for mitral regurgitation assessment, whether it's for aortic stenosis, and also, especially in the case where there's combined valve lesions, where you have both MR and AI, where echo can be really limited in trying to determine the severity. Those are cases where a patient will get referred on for an MRI scan. Let's get past here for AS also. For pericardial disease, MRI can be useful in identifying thickening of the pericardium as well as inflammation of the pericardium, which could be responsive to medical therapy. In patients with heart failure, beyond LV function, where MRI is useful is the ability to do scar imaging. And this is one technique that cardiac MRI is unique in, is the ability to directly image or visualize myocardial scar. And there's actually a very tight relationship between the amount of scar that's present and the likelihood of improvement in contractile function, both in the setting of chronic CAD, of acute CAD with acute MI, or in the setting of patients with congestive heart failure. Let me skip past this here and just show you some example cases. This is a patient who, or there's two patients here, both who have heart failure, both who have LV dysfunction. We could have seen this by echo. But what the MRI helps you to identify is the patient on the left has no scar within the myocardium. See, there's no bright areas. The patient on the right, on the other hand, has this hyperenhancement here in the anteroseptal wall. So the patient on the left is a non-ischemic cardiomyopathy. The one on the right is an ischemic cardiomyopathy, and that's in fact what we found by coronary angiography. So again, patients coming in with heart failure, MRI can help you not only in identifying if it's heart failure with preserved EF or reduced EF, but also if it's depressed EF, is it ischemic in origin or non-ischemic in origin? It can also help you identify the potential cause of the cardiomyopathy. Here's an example of a patient with hypertrophic cardiomyopathy where you see a thick wall and you see these hyperenhancement areas in the septum, and the amount of hyperenhancement in HOCM correlates with prognosis in these patients. So the more hyperenhancement, the worse prognosis. It can also help with Takotsubo's cardiomyopathy, and this is actually a very nice study published in the JAMA, which described the classic apical ballooning syndrome that you can see, but also notice you can have some patients who have a mid-ventricular ballooning syndrome, or you can have some patients who have a basal ballooning syndrome. So differing forms of this Takotsubo's or stress-induced cardiomyopathy. And then some patients who have biventricular ballooning syndrome, where both the LV and the RV demonstrate a ballooning pattern. Myocarditis, MRI can also help us in identifying if a patient has myocarditis, and also help in prognosticating. You can see from these survival curves that those patients with suspected myocarditis who have no hyperenhancement on the CMR have a much better prognosis than those who have evidence of hyperenhancement. And also for amyloid heart disease, the contrast-enhanced MRI findings where you see diffuse uptake everywhere in the myocardium is very classic finding that you see with amyloid or infiltrative heart disease. So this can be useful from a prognostic standpoint as well as a diagnostic standpoint. And then let me run through real quick here non-compaction. You can see here this prominent non-trabeculated, non-compacted myocardium. And then lastly, let's wrap up. So where's MRI going to be helpful is one is identifying heart failure with reduced EF from heart failure with preserved EF, discriminating ischemic from non-ischemic cardiomyopathy, and then the patterns of hyperenhancement that you see on CMR can aid both in diagnosis as well as in prognosis. And so again, there's appropriateness criteria for cardiac MRI as well that you can go to and find, which can tell you what are the appropriate indications. And then the last point is always make sure, we want to stress safety. We want to make sure we practice safety as well. You can see in this cartoon, he's stressing safety, but he's not really practicing safety. All right, thank you all for your attention. Do you have time for questions? Yep. Okay, couple minutes for questions, I guess. Or comments. It's a lot of stuff to go over.
I guess my question would be on just heart failure.
Yeah.
Every patient that comes in, if they don't have an EF within a year, we do a test.
They should get an echo, correct.
Core measures.
Right, so absolutely. If a patient has not had any prior assessment of LV function, and they have heart failure, they definitely need assessment of LV function. Typically, you would start with echo, and if the echo is suboptimal or equivocal, then you could proceed on to something like MRI. But the flip side is, if you have a patient who, you look at the chart and they've been in the hospital every month with recurrent heart failure, that's a patient that getting a repeat echo may not be of use.
We keep doing on every, the patient comes in with pneumonia. Oh, we don't have an echo from the last year. So nothing related to CHF, but
right.
We do them on every
right. And that's why I say all dyspnea is not equivalent with heart failure, right? So if a patient comes in with dyspnea and they clearly have a pneumonia, that's not a heart failure patient. There's not really an appropriate indication to get an echo. And I think that's where maybe just a simple BNP could actually be helpful. Because the BNP is normal, less than 80, it's very unlikely that this dyspnea is due to heart failure, and you probably don't need to go down that pathway. Now, keep in mind, BNP is nonspecific. So if you have a high BNP, it does not necessarily mean they have heart failure, because AFib can cause a high BNP. Other things can cause a high BNP as well. But if there's a normal BNP less than 80, it's very unlikely that it's heart failure.
Let me ask you a kind of follow-up question on that, because I had a patient one time who had a BNP of 8. And her EF was like 55, maybe it was 50, 55. But the cardiologist in the chart, and I never saw him to ask, but said, oh, CHF. I mean, so would that be a diet? I told them, I said, I'm just the nurse. I don't know nothing.
Yeah.
Ask the cardiologist, because maybe it's diastolic, but I don't understand 8 and 50 to 55, and that's
right.
Heart failure.
Right. So one thing, I mean, obviously, as I talked on, EF alone doesn't necessarily rule out heart failure, because you can have normal EF and still have heart failure, right? Heart failure is a clinical syndrome, but if you have a BNP of 8, it's very unlikely that this person has heart failure, at least not decompensated heart failure, right? You may have a history of heart failure, but they may be very, very stable, because a BNP of 8 tells you their filling pressures are quite normal. So I think you're absolutely right saying that if you've got a BNP of 8, it's very unlikely that this person's dyspnea symptoms are due to heart failure. You should look for something else. Yep.
I had
Yes.
a quick
Question over here. Oh, I'm sorry, there's a microphone back there. Sorry, 1 second.
just had a quick question. When you're talking about the appropriate indications for ordering echoes, you mentioned about it's appropriate to order an echo for initial assessment with hypertension, but not for subsequent assessment. So what part after the diagnosis, at what point after the diagnosis of hypertension?
And if you look at the appropriate criteria, there was initial assessment of hypertension with suspicion of hypertensive heart disease. So if somebody just says, I've had hypertension for a few years, controlled, that's probably not an indication. But if they have EKG changes suggestive of LVH, they have physical exam findings suggestive of LVH or hyperdynamic heart, those are all indications that it's appropriate to do initially. And then from that point onward, if there's not a change in clinical symptoms, you don't necessarily need to keep repeating doing echoes on those patients. Now on the other side, if they're decompensating, their EKGs are changing, getting more voltage, they're developing symptoms of shortness of breath, exercise tolerance has gone down, those are indications where you're looking for a change from before, then it'll be appropriate to then get a repeat echo.